Welcome to the conference session titled Ask the Expert Pediatric Parents Session. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Throughout the presentation, please feel free to submit your questions for our experts to answer. This is a Q&A session, so there will not be a formal PowerPoint presentation. To submit your questions, please use the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question or comment in the Q&A box, and when you have finished typing, just hit enter. We'll do our best to get to all the questions today. When asking questions, I do ask that you do two things to help us manage the incoming question. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our experts cannot answer any specific questions related to your child's health care. At the beginning of the session, we do have a poll that is open. Please feel free to answer the poll. You can open the poll by using the poll icon located in the right part of your screen. Today's specialists are Akiko Shimamura and Timothy Olson. Dr. Shimamura is the director of the Bone Marrow Failure and MDS program at the Dana-Farber Boston Children's Center and Blood Disorders. Dr. Timothy Olson is the medical director of the Pediatric Blood and Bone Marrow Transplant Program at Children's Hospital of Philadelphia. I'd like to welcome Dr. Shimamura and Dr. Olson. Thank you for joining us today. So our first question is, what is bone marrow failure? Would one of you like to start with that one?
I'm happy to start, and Dr. Olson can chime in. So bone marrow failures refers to a condition where the blood counts are low because the bone marrow is not producing blood cells. So it's a situation where the bone marrow is failing to function adequately to produce blood cells, is sort of a general way to think about it.
Dr. Olson, would you like to add anything to that, or?
I think that sums it up perfectly. I think many of us, when we use the term bone marrow failure, it also implies that we don't think that the marrow is going to get better on its own, which differentiates what we consider to be a bone marrow failure condition from some of the other things that can temporarily suppress bone marrow function, such as infections or other stresses. But I think Dr. Shimamura summed it up nicely.
Thank you. How does pediatric aplastic anemia, or MDS, differ from adult MDS or aplastic anemia? Dr. Shimamura or Dr. Olson, which one would like to go first?
I'm happy to start on that one. So, I think pediatric aplastic anemia and MDS, I think, has a pretty strong, or MDS that arises from pediatric aplastic anemia has a pretty strong immunologic footprint. Whereas in older adults who develop aplastic anemia, and who may go on to develop MDS, there's an association with mutations that arise with age that can be associated with the development of those conditions in older adults. I think in younger children, I think there's more often an identified immunologic trigger, such as a viral illness that precedes the development of immune-mediated aplastic anemia. And then I think one of the big differences is where patients who develop MDS, where that arises from. So we think that In the majority of cases in pediatrics, MDS arises from patients who are born with genetic mutations that predispose to the development of MDS, whereas in older adults, MDS is often associated with these age-related mutations. Dr. Shimamura, I'm sure you have many good things to add.
I thought that you covered all the main points really nicely. I think that you allude to an exciting time in our medical armamentarium where we can utilize precision medicine approaches to try to pinpoint, as in many cases, the genetic cause of pediatric MDS and sometimes bone marrow failure as well. And this is important because this informs the treatment of these conditions, and we can tailor the therapy appropriately. So it's an exciting time in the field where we have a lot more precision in our approaches to the treatment. I guess I would also add that in pediatric aplastic anemia, severe sort of what we call idiopathic aplastic anemia, where we're not sure of the cause and it appears to be immune mediated, as Dr. Olson mentioned, the responses of children to immunosuppressive therapy tend to be much better than the rate of responses in adults. So in children, we tend to have a higher rate of response to immunosuppressive therapy, and we're still trying to understand the causes of that. And I think Dr. Olson nicely laid out some of the things that we understand right now.
Thank you. We have a question and would like to know, besides having a bone marrow biopsy, what other tests should be done to confirm that your child has the correct diagnosis, whether it be aplastic anemia, MDS, or PNH, or even bone marrow failure in general? What other tests besides a bone marrow biopsy need to be done? Dr. Shimamura, would you like to start?
Maybe we'll switch off taking the first shot. Otherwise, we sort of nod at each other like, do you want to go? So that's a great question. I'll start it and I'll let Tim elaborate. First, I'll talk about the marrow, and what's important is first starting with the marrow, but the specific tests that are done for the bone marrow. So we, if possible, like to obtain both an aspirate, which is where you take a syringe and remove some of the liquid part of the marrow. You can do some very precise tests on that, which nowadays includes not only looking at how the cells look and appear, but also looking at the cytogenetics, that is the chromosomes, to see if there are some changes in the chromosomes, using a fluorescent probe to do something called FISH, fluorescent in situ hybridization. And these are very sensitive methods to try to look at some of the differentiation between bone marrow failure and MDS. And lastly, we're now including in our armamentarium some of these more genomic cutting edge approaches to look at acquired changes in the bone marrow that I know Dr. Olson can talk some more about. That can help sway you in one direction or the other with respect to the diagnosis and for the treatment. In addition, outside of the marrow and looking at the blood counts, as Dr. Olson alluded to, it's important to rule out other conditions that might be suppressing the bone marrow. So the bone marrow may be intrinsically healthy. It's just something else has happened to it, such as an infection or a certain medications or sometimes other conditions. And the reason that's important is if you treat these other conditions, the marrow, which is intrinsically healthy, can now recover. So you want to treat the other thing that is causing the bone marrow to be suppressed. We have additional other tests that we send off to look for some of these other conditions. Another one that the Aplastic Anemia MDS Foundation has played a really important role in helping us move forward is PNH. So we would approach PNH differently from sometimes bone marrow failure or aplastic anemia or MDS. So you want to send off PNH testing. The genetic testing that I just alluded to for the bone marrow is different from the diagnostic genetic testing that we look at for causes more intrinsically, not just in the marrow, but as Dr. Olson was mentioning, sometimes there are genetic causes that aren't acquired, but are just part of who we are that can increase our risk of bone marrow failure or MDS. And then lastly, depending on the clinical situation, there may be additional tests. So I think the bottom line is it can be helpful to seek input from a center with a lot of experience and expertise in these disorders, because the field is rapidly advancing, and seeking out expert advice can be very helpful. I'll let Tim take it from here.
I think that was perfect. The one thing that I would add, only because when I speak with families, sometimes a point of confusion is the genetic testing, which Dr. Shimamura covered nicely. The way I tend to phrase it is that there are two things that we do genetic testing for. One is to try to figure out where this came from, and the second is where it's going. So the where it came from, we'll often do off of a blood sample. Sometimes we'll actually do it off of a skin tissue sample to try to figure out what genetic changes was the patient born with that is predisposed to the development of this, and how does that impact our approach to therapy. The second piece, which I think to us is becoming equally important, is can we identify changes that have arisen in the bone marrow cells, in the blood cells themselves, in response to the immune response that caused the aplastic anemia, that can predict for us where this might go in the future, and how that might impact the therapy choices that we want to make. Akiko mentioned PNH. That's one of the clonal diseases that we think arises out of aplastic anemia, but we're starting to learn about other types of clonal abnormalities that can arise out of aplastic anemia. Not all of which are bad, but a lot of them can impact, what we think might happen down the road, and impact what we want to do therapy-wise.
I would just add to that because Dr. Olson is doing some really interesting research in this regard, and we're also doing research in different aspects of this, as many groups are trying to find markers to predict outcomes. Wouldn't it be nice if we could predict who was likely to respond to immunosuppressive therapy, and conversely identify patients unlikely to respond and who might benefit from alternative therapies up front? Currently, we don't have such methodologies, but we're all working very hard to move that forward. And the Aplastic Anemia MDS Foundation has been funding this type of research, for which we're very grateful.
Thank you. Once your child receives a diagnosis, how does a parent decide what treatment is best? Specifically with aplastic anemia, you could go the drug therapy route, or you could look for transplant. So what goes into the factors of deciding what is the best option for a child?
I will start with this one, and I think this should lead to a very good sequence of discussion with Akiko and myself. So I think the first thing that we look for in terms of treatment, particularly if we have done the diagnostic evaluation that we were just discussing, and at the end of that evaluation, we are confident in the diagnosis of idiopathic or immune-mediated aplastic anemia. The first thing that we look for is to identify whether a patient has a full biological sibling who may be a complete HLA match. So if a sibling with the same mother and same father is tested, there is a 25% likelihood, roughly, that sibling would be an HLA match. And if we identify a match, and if that sibling is healthy and does not have any excluding medical conditions, then our treatment of choice is always going to be matched sibling donor bone marrow transplant if a patient has severe aplastic anemia, and that's defined based on the levels of blood counts that they have, along with an empty bone marrow. For patients with moderate aplastic anemia, that's a bit of a different discussion, and I'll leave that perhaps for later. But for a patient with severe aplastic anemia, the treatment of choice, if it's available, is a matched sibling donor bone marrow transplant. And the reason for that is there's decades of experience now with this, which suggests that the likelihood of a long-term cure of aplastic anemia with matched sibling donor transplant exceeds 90%. In some series, it's exceeding 95%. And so that's our treatment of choice. I think where this becomes a little bit more difficult is if you don't have that matched sibling donor, which is the case for the majority of patients. Historically, we all agreed that the next line of therapy in this situation would be immune suppression therapy. And that's because historically, we quite frankly weren't as good at doing unrelated donor bone marrow transplants as we were at doing matched sibling donor bone marrow transplants. And so the likelihood of success was a lot lower. I think where there is becoming more equipoise and where it's becoming a little bit more difficult to navigate right now is, in fact, outcomes with alternative donor transplants have improved a lot over the last decade in particular, due to a number of factors. And so this is leading to research and change of practices at some centers as to what you do next, whether it's immune suppression therapy or unrelated donor transplants. And I think with that, I think that's a good point at which to kick this over to Akiko for her thoughts.
I agree with that. It's been an exciting advance in the field of unrelated donor transplants if you have a fully matched donor. And so maybe I'll start, I'll carry on where you left off, and then I'll let you finish, because there are some things that I think it would be fun to explore at the end. So traditionally with immunosuppressive therapy, which was used back when transplants outcomes for unrelated donor transplants were not as good as they are now. The advantage is you can start it right away, but the disadvantage is it takes a long time to work. It often takes 2 or 3 months before the blood counts improve, and it can take 6 to 12 months to really get to the final optimal response that you get. The risks of immunosuppressive therapy up front are not zero, but they're usually quite manageable. And so the issues really become, not everybody responds. Of the people who do respond, there's a variation in how well they respond. We have a pretty low bar for what we call a response. We say you're a responder if you no longer need transfusions and your neutrophil count is greater than 500. But as you might imagine, there are blood counts that don't need transfusion but could impact your lifestyle, your quality of life. So those patients who have a nice response, what we call a complete response, is higher in children than in adults, but it's still not significant. It's still significantly lower than what we wanted. It's probably on the order of about 20–25% of children historically have achieved a complete response, and in more recent studies, perhaps a little higher. The other issue is with immunosuppressive therapy, there is a risk of relapse. So even if you respond and have a great response, there's a risk that you could lose that response and relapse back to severe aplastic anemia. And there's not great data on the time frame for that. So it's hard to say by this much time after you stop treatment, you are home free. And because when we look at the graphs, we're not seeing a nice, clean, what we call a plateau, where they relapse and then they plateau. So we're still trying to understand that. And for children, that's a big deal, because we want them to have decades and decades and decades of lifetime ahead of them. So in terms of risk, long-term risk, that's a significant issue to consider for a child. And then lastly, there is a risk over time of progressing to what we call MDS, which maybe we should define. And MDS is defined as what we call a clonal disease, meaning that something has happened to what we call a stem cell or an early cell that then gives rise to daughter cells or baby cells. We always call them mother cells and daughter cells, but they can be father cells and son cells too. We don't want to be, biased in this regard. Parental cells and progeny who inherit that same abnormality, and there is an increased risk in that situation of low blood counts and progression to frank malignancy, that is leukemia. So MDS is a situation that we take very, very seriously and requires urgent treatment in children. And some people long-term after immunosuppressive therapy may develop MDS or AML. So although the upfront risks of immunosuppressive therapy are fairly low, there are potential long-term risks that if they develop can be significant. That contrasts with transplant, which since Dr. Olson is a transplant expert, I'm going to let him talk about the pros and cons of transplant.
Thank you. I think that was a great summary. When I talk about this decision with families, I really emphasize that the difference between these therapies is immune suppression therapy is a safer therapy with very little, I wouldn't say zero, but very little upfront risk of mortality, it is less disruptive to the patient's life, family's life, and the few months after it than a transplant is. So it's a little bit less intensive. So it's a safer and less intensive therapy. As Akiko mentioned earlier, if we knew the patients that were going to be great responders to it up front, it's the right therapy because it's safer, it's less intensive. The problem really comes down to the number of patients for whom it ultimately is successful. And that percentage varies based on the study that you look at. But unfortunately, if you aggregate all of those studies, even in pediatrics where patients respond better to immune suppression therapy than adults, I usually arrive at a number that for only about 50 to 60% of patients will that cycle of immune suppression therapy be the only therapy that they ever need. So let me get to transplant. So transplant's risks are very different. Most of the risks are within the first 1 to 3 months of the transplant. Transplant involves a 5-week, at a minimum, admission to the hospital. It involves the use of chemotherapy to eliminate the immune system of the patient. And we want to eliminate it because it's the immune system of the patient that we think has caused the disease in the first place. And if we don't eliminate it, we worry that abnormal immune response will kick out the donor cells, what we call graft rejection after a transplant. So it involves the use of chemotherapy, which can have short and long-term side effects. Patients will develop nausea as they go through this. They'll develop what we call mucositis, which is sores along the GI tract from having their counts very low and having received chemotherapy. Because we fully ablate the immune system, the risk of infection during the first couple of weeks after a transplant is considerably higher than with immune suppressive therapy. And patients need to stay in the hospital until the new cells start to grow so that they are safe to return home. Just like with immune suppression therapy, I think the receipt of a transplant relies on expertise of centers who have done this not only for any patient who needs a transplant, but specifically for patients with aplastic anemia, because some of the needs are a little bit different after a transplant in that population, particularly with respect to the risk of certain types of infections, because patients are coming into the transplant with low blood counts, and also with respect to rejecting the graft. If all goes well, patients recover their blood counts a lot faster after a transplant than with immune suppression therapy. The goal in our center is to get up to near normal blood counts within 30 days after the transplant, and hopefully become transfusion independent at that point. And I think that's the case with most modalities across the country and the globe now, that is the goal. Hopefully patients are able to go home from the hospital 5 weeks after a 5-week admission, but it does involve weekly follow-ups in a transplant clinic until you're at least 3 months out from the transplant, because there are a few things that we still worry about during that time frame. Even though neutrophils recover after a transplant quickly, we know that it takes about 4 to 6 months for the immune system to fully get back to normal. And during that time, there are still risks for certain types of viral infections that we monitor for in those weekly visits to clinic after treatment. There's a risk of rejecting the graft, and if that happens, then patients need to go through a second transplant. And then there's the risk of something that's called graft versus host disease, which is in many ways the opposite of risk of rejection. It's when the immune cells of the donor recognize the patient's body as foreign and begin to attack it and produce a type of autoimmune disease. In its simplest form, this can involve some eczema-like rashes that can be managed with topical treatments and occasionally short courses of steroids. But if severe graft versus host disease develops, it can really involve almost any system in the body, and it can be devastating, and in many ways can be worse than aplastic anemia itself. I think where the revolution has come with unrelated donor transplants and even haploidentical transplants is our ability to devise methods to prevent graft versus host disease. And I think in the modern era, whereas we don't think that we can fully eliminate the risk of graft versus host disease, we think we can minimize it. And specifically, we think we can minimize that risk of severe graft versus host disease after a transplant. So bottom line is the first 3 months after a transplant are very intensive. We don't allow patients to go back to school after a transplant until at least 6 months, at least in our center. That may vary depending upon the center. But because we want the immune system to be able to handle the types of exposures that patients are going to get when they go back, that's why we keep them out until 6 months. We require that they receive childhood vaccinations again after going through a transplant because they have a brand new immune system that they have to build back up. And that process starts in our center around 8 months, but across the country, it would probably vary between 6 months and a year after the transplant. So the bottom line is it's a really intensive process that is unquestionably going to disrupt life in a family for 6 to 12 months. So why would anybody choose that over immune suppression therapy? The reason is, in the modern era, I already mentioned that sibling donor transplant works 90 to 95% of the time. We're not quite there with unrelated donor transplant, but we're getting close based on recent data to where we think the likelihood that this will be the only therapy you'll ever need is in the 80 to 90% range now. And that likelihood is simply higher than the likelihood that it's the only therapy you're ever going to need if you start with immune suppression therapy. So I think the big question for the field right now and for families is, should we try immune suppression therapy first, knowing that if you're in the 50% of patients that it's going to work well for, that's going to be the safest, least intensive therapy you can go through, and that's great. But knowing that the likelihood that that's the only therapy you're ever going to need is a little bit lower than with unrelated donor transplant. And I think that's the big question in the field, and Dr. Shimamura and others are leading a study that you may want to comment on that is hopefully going to help us figure out this question of what the right starting point might be for patients who don't have a sibling donor for transplant.
That was terrific. Thanks so much for that very clear discussion of transplant versus immunosuppressive therapy. So I'll just follow up with, you gave me a nice lead into a study that Dr. Olson is also a leader in, which is called the Transit Trial, where we're trying to answer this question. The only way to really rigorously address this question is to randomly assign patients to one treatment or another. And so as patients come in, if they agree to the study, they are randomly assigned to immunosuppressive therapy versus unrelated donor transplant, assuming, provided that they have appropriate donors available and that they're appropriate candidates from a medical standpoint for transplant or immunosuppressive therapy. And we've published a pilot study that's been completed, and now we're trying to initiate the full study. But in the pilot study, we demonstrated that it's feasible to do this. We didn't even know, starting out, whether we could get our patients to transplant quickly enough to be safe, right? Because it takes longer to get a donor search going and all those sorts of things, as opposed to immunosuppressive therapy, where I can start it tomorrow if I have to, right? But the issue is immunosuppressive therapy will take a long time to work, whereas, as Dr. Olson said, a transplant hopefully will have your blood counts in a good range within about a month of starting the transplant. There's just more of a delay to the transplant. And what we found was that the time to treatment and the time to get your counts back was not significantly different between the two, and it was quite feasible to get patients to transplant quickly if you're at an expert center that has the mechanisms in place to make that happen. You don't want to delay treatment for severe aplastic anemia, particularly if you're severely neutropenic. You want to move, as expeditiously as possible to treatment. And then I would just reiterate, as Dr. Olson mentioned, that the goal of transplant is to give you a healthy marrow. So now you don't have to be concerned about the aplastic anemia coming back. This is the most curative, definitive therapy, when all goes well, for severe aplastic anemia, as opposed to immunosuppressive therapy, where there does continue to be, the marrow is still there, your own marrow that was aplastic is still there, and there's a chance that the aplastic anemia could come back, or other complications could arise. Dr. Olson, could you, just to follow up on this, could you comment a little bit on sort of potential long-term toxicities of transplant for the types of regimens that we use for severe aplastic anemia?
I think this is a critical point, and I'm glad you asked this question, because I forgot to mention it in my last talking points. The regimens for aplastic anemia invariably involve a medication. The transplant regimens for aplastic anemia invariably involve a chemotherapy medication called cyclophosphamide. Most of the regimens for unrelated donor transplants also involve a low dose of radiation. And it's between those two things that we think many of the long-term complications of transplant may arise. So one of them is concern for fertility. There have been a few very good long-term studies for matched sibling donor bone marrow transplant that look at risks of infertility after that. And the good news is, for matched sibling donor transplants, which involve the use of cyclophosphamide, but not necessarily the radiation, for patients who undergo the transplant before the onset of puberty, fertility outcomes, while I won't say they're not affected at all, but generally speaking, fertility outcomes appear to be very good in those patients. And that's in contrast to if you go to a bone marrow transplant as a young child for MDS or for leukemia, where we have to use stronger intensity regimens in the transplant to make sure that the MDS or the leukemia doesn't come back. For patients who undergo transplant after puberty, there is more concern for those patients that even the lower intensity regimens that we use for transplant and aplastic anemia could have long-term impacts on fertility, and for females, long-term impacts on ovarian function. For boys, it's the way around this, if you are post-pubertal, is sperm banking. It's fairly straightforward, and even for patients with severe aplasia, sperm banking is an option. For post-pubertal females, the choices are a little bit more complex because, yes, there are good fertility preservation methods such as egg retrieval or ovarian tissue preservation. The problem is for patients with aplastic anemia where the neutrophil counts are very low and the platelet counts are very low, there are risks with undergoing those procedures going into a transplant, and that really has to be discussed on an individual basis as to whether or not pursuing those options are going to be worth those risks. The other things that we can see long-term are that you can see abnormalities in hormones. One of the big ones is thyroid function. Patients who have developed aplastic anemia are generally at risk for abnormal thyroid function for reasons that we don't entirely understand, but we think might be linked to shared autoimmunity. We do see abnormalities in thyroid hormone function after both immune suppression therapy, but probably more so after transplant, which may require thyroid hormone supplementation. There is some concern about growth in prepubertal patients, although most of the studies have suggested to expect normal growth after transplant. Some of the concerns regarding organ function, lung function, which we have in other types of transplants, we worry about a little bit less in aplastic anemia because we don't use the types of therapies that are most associated with abnormal lung function. However, if you do develop graft versus host disease that involves the lungs can have long-term effects. We worry about kidney function, really with both immune suppression therapy and with bone marrow transplant because of one of the medicines that we use to help with immune suppression in IST, which is similar to the medicine that we use to prevent graft versus host disease after a transplant, which is cyclosporin or tacrolimus in some cases. And so that needs to be monitored long-term. And then I guess the last risk of transplant, which is an interesting thing to talk about, is the risk of secondary cancers. So anytime you use radiation or you use cyclophosphamide, which is the type of chemotherapy medicine that can lead to secondary cancers, there is a risk of secondary cancer. The types of cancers that we see after a transplant would include things like thyroid cancer. You have a higher risk of skin cancer, for example. Those are risks. They're relatively low risks on the order of a couple of % or so. And one of the ironic things about transplant in aplastic anemia specifically is because of the risk of MDS and leukemia after immune suppression therapy for aplastic anemia, it's actually not clear to me that the cancer risk is any higher after undergoing a transplant, which may be more curative and prevents those MDS and leukemia risks than the cancer risk is after immune suppression therapy.
Thank you. And this question comes from a parent whose child had a transplant 6 months ago. When is a transplant considered a failure? Is there a specific criteria? And if the transplant is considered a failure, what then?
So I think I should probably take that one first, and I'd love to hear your thoughts, Akiko, as well. It's a little hard to define after a transplant. Sometimes it's easy to define, unfortunately. If blood counts don't come up after a transplant, or if they fall back into the range of aplasia after a transplant, it's fairly easy to define that a transplant has not been effective. There are other scenarios where it's a little bit less clear. So sometimes you can have what's called graft dysfunction after a transplant, where maybe a couple of the bloodlines, for instance, the neutrophils of your white blood cells, and maybe your hemoglobin is okay, but perhaps your platelets are not behaving the way that we would want to after a transplant, and you might occasionally still need a transfusion or two. That's where you fall into the category of graft dysfunction after a transplant. And that's a little bit trickier to assess what the next step might be. Sometimes you can do things like stem cell boosts to try to boost the production of blood cells without having to go through an entire second transplant. For patients who have the more clear failure of the transplant, which is usually thought to be caused by immunologic graft rejection, then really our only choice is to do a second transplant. Who we use for the donor in a second transplant is dependent upon who we used for the donor the first go round and how many options we have. Oftentimes if we have an option that we think is equally as good, that is different than the original donor, we'll try to go to a second donor. And the reason that we do that is we think the reason that the first graft didn't work is that it was actively rejected by whatever surviving parts of the immune system were there in the patient. And so we want to go to a different donor because hopefully there isn't still an immune response to that second donor. That being said, we have had the occasion, particularly in haploidentical transplants, where we only had one option for a donor, which was apparent the first go round. A patient had rejected that graft. We've used that same parent again for a second transplant, and it's been successful. You do unfortunately have to undergo more conditioning chemotherapy for that second transplant. And the biggest risk of rejecting a graft after a transplant is the added time that a patient spends with very little immune function and the additive risk of developing a significant infection. Bacterial infections we can often handle, but we worry about other types of infections, including virus infections and fungal infections.
That was terrific, Dr. Olson. I would just add on a related topic that particularly if a graft has failed where the donor was a family member, it's helpful to make sure that there was an assessment to make sure even a seemingly healthy family member might have, if there is a sort of genetic risk to bone marrow failure, that a marrow that's donated from a family member who actually carries that same genetic risk, even though they seem clinically healthy, can confer that with the transplant such that the transplant fails. So making sure that either your primary doctor looks hard at that question. Sometimes it just happens and we don't know why, but sometimes if you can find a reason, it informs how you move forward. That's a time when, if necessary, it's helpful to seek expert input from centers that think about this a lot.
Thank you. Our next question is, are there different types of pediatric MDS, like what we see with adults using the IPSSR scoring system?
Shall I start on that one, Dr. Olson? So in pediatric MDS, interestingly, it's quite different actually from adult MDS. And both Dr. Olson and I were involved in the World Health Organization sort of update of the classification of MDS, particularly in pediatrics. The classifications that we use for adult MDS don't work for pediatrics. For the most part, pediatric MDS is what we call high-grade MDS. You don't get sort of the low-grade MDSs that you get in adults where it sort of smolders along for years and years and you don't have to do anything. In pediatrics, it's generally high-grade and you want to intervene. And in pediatrics, even the diagnostic criteria don't quite fit all the criteria that are classically used in adult MDS. So really seeking I know I keep saying this, but it's because it's such a rapidly moving field that making sure you've got expert input on this is important. And the classification, although there are some general classifications that sort of crossover from pediatric and adult. So you can have in pediatrics, I don't know that it makes a whole lot of sense to go through each little classification, but in broad strokes, we have what we call refractory cytopenia, where the MDS is present and the blood counts are low, but you're not getting an elevated blast count, right? That's sort of a lower grade than where you have an elevated blast count, and the how high grade we call it, it depends in part on the blast count, but also other clinical features, such as the cytogenetic features, sometimes the somatic mutations now that we're able to look at, as well as the underlying cause of the MDS can impact how we put this all together. But in pediatrics, we don't tend to do sort of temporizing measures to just sort of let the patient sort of smolder along as long as their counts are okay. We need to intervene for children because they tend to have the type of MDS that will progress quickly if you don't intervene. I'll let Dr. Olson add to that.
Yeah, and I think that was a great summary, and I'll add on that, I'll add on explicitly that we think that nearly all pediatric patients for whom we think it's eligible based on their overall medical status, we think the only way that we're going to cure those patients is with transplant, and particularly for patients who have disease features that look aggressive. You know, our goal, which is very different than older patients with MDS in adult medicine, our goal is try to expedite getting to transplant quickly. Now, there are a few debates that we are designing trials to try to address, which is, for some patients, would it be better to try to bring down the burden of the clonal cells, particularly for those who have excess blasts associated with their MDS, by giving them a couple of cycles of low intensity chemotherapy before we come into transplant? Would that be the best approach? Historically, we have tried to take these patients as quickly as possible to transplant, but we're reevaluating this. Now, I will say as a transplant physician, MDS remains one of the trickier things to successfully do a transplant for. And there are a few different reasons for that. One is there are two different things that you're wanting to avoid with respect to transplant failure in the case of MDS, whereas with most other conditions that we do transplants for, we only have to deal with one of them. So in MDS, we have to worry about graft rejection because, particularly for patients who don't have sibling donors, because patients have not typically come to the transplant with a lot of immunosuppressive chemotherapy before they've arrived. And so we have to tailor the regimens and tailor our prophylaxis after the regimens to try to prevent graft rejection. At the same time, we have to worry about disease relapse. And unfortunately, oftentimes after transplant for MDS, if disease comes back, it oftentimes comes back as AML or acute myeloid leukemia, which is more severe in terms of what needs to be done to get that under control than even MDS was. So we are still working as a community to try to figure out the optimal approaches for transplant for patients with MDS. The last thing that makes it difficult is that a lot of the genetic predisposition conditions that lead to the development of MDS are associated with problems outside of the bone marrow and blood system as well, organ system dysfunction. And we have to be very careful with the regimens that we choose in transplant so that we don't excessively injure organ systems for patients who may not be able to tolerate conventional doses of chemotherapy or radiation. So it is a tricky disease to do transplants for, but at the same time, I think there is universal consensus that patients who have true MDS in childhood, we try to get them to transplant if at all possible.
Thank you. Our next question is, What is MDS with monosomy 7?
I think you're up, Tim.
I can start with this one, but I know Akiko has many great insights on this as well. So monosomy 7 is a genetic marker, and it is the most common genetic marker of MDS in childhood, which makes childhood MDS look a little bit different than what is common in older adults. What it is the loss of one of the chromosomes. So everybody has 46 chromosomes, 2 copies of 22 of those, and then an X and an X, or an X or an Y chromosome. So chromosome 7 is one of these chromosomes. And there are a variety of genetic conditions in which that are predisposition conditions for MDS, that if you develop MDS, it's very likely that the genetic change that defines your bone marrow stem cell turning into an MDS stem cell is the loss of chromosome 7. And the reason why it's advantageous for this to happen in the bone marrow is something that's being intensively studied. And we think it might be different in different patient populations in pediatrics as well. But I think the common theme of it is, by losing a copy of chromosome 7, it helps the bone marrow cells start to divide more and produce more cells. But unfortunately, those cells that are being produced are abnormal. And this leads to instability of the dividing cells, such that they're more likely to develop more mutations that can then go on and progress from just MDS to AML. So I think with that, I've said probably all I should say as a transplant physician, and I'll turn it over to Dr. Shimamura.
I always enjoy hearing what Dr. Olson has to say. So I would just say that traditionally, the observation of the loss of one copy of chromosome 7, monosomy 7, in the context of MDS is considered a high-risk feature, meaning you don't have the luxury of a lot of time to sit around and watch it. You want to make plans to move forward to transplant if you have MDS with monosomy 7. Now, there are situations, though, in which monosomy 7 arises as the sole abnormality, right? The other features that make you think this is MDS may not be present. And by that, I mean sometimes there are certain changes in the way the cells look that push you towards monosomy 7, MDS. Or there may be other features, other clinical features of MDS that make you say, this is MDS with monosomy 7. Other times you have an isolated monosomy 7, right? But you have no other features of MDS. And there it's more complicated what to do. And what we've learned is, in some patients, it's reasonable to watch and watch very closely with an expert who knows what to watch for, to make sure that it's not progressing in the wrong direction, in which case you've got to intervene with transplant. Versus in some patients, it actually disappears, meaning we no longer can detect it and it goes away. So it's a complicated issue, monosomy 7, and it depends on the company it keeps in part. And we're starting to understand some of the mechanisms of those. We and others, including Dr. Olson, have been really intensively studying some of the conditions that predispose to monosomy 7, and what are the features that push us to intervene quickly versus watch and wait very closely versus breathe a sigh of relief. So, but monosomy 7 is always taken seriously, but it's more complicated nowadays, now that we understand more of the complexities.
Just want to add one more comment. I think that was great. But to whomever asked that question, and whomever else is out there who's wondering about monosomy 7, I think the one thing that I would advocate for is, if your child has been diagnosed with monosomy 7 MDS, there is a very high likelihood that if you have monosomy 7 MDS, that there was a mutation that you were born with, that patient was born with, that led to the likely development of this. And so I would ask your physicians, if you haven't already had this conversation, to make sure that they have looked for a genetic predisposition condition as to why this developed, because identifying that predisposition condition might well have significant impacts on your therapy and therapy considerations in general.
Thank you. We have another question, and I know I'm going to completely mispronounce one of these diagnoses, so please forgive me. Is there a link between other disorders, specifically hypophosphatemia, and autoimmune disorders such as pernicious anemia or eczema in children that ultimately develop MDS?
I think I'm up, but I didn't quite catch the first term, but I think we can start to address this generally. And then if whoever else asked the question could clarify whether we're totally off base in our understanding. My general sense of the question is there an association between immunologic abnormalities and MDS? So that's the question I'll address. And if that's incorrect, please clarify in the chat. So we are increasingly seeing an overlap between bone marrow failure and immune abnormalities, immune dysfunction, dysregulation, and also MDS and immune dysregulation. And the immune dysregulation may be either underlying immune condition, right, that it affects the patients, or it may be something that the immune system acquires that is then driving MDS or bone marrow failure. So you can have both, sort of like what Dr. Olson, I think, really nicely described for genes that you can be born with that can predispose you to bone marrow failure, or you can acquire hits to your genes in your bone marrow that can then push your disease in certain directions. So similarly with the immune system, you can sort of be born with an immune condition, or your immune system may be reacting or be driving things just as an acquired condition. So that's absolutely an issue. We are increasingly integrating, and Dr. Olson and I just headed a group to try to come up with sort of standard practice within our pediatric consortium. We have a national consortium called NAPAC, where we're banding together across the country to accelerate research and improve outcomes for children with aplastic anemia and MDS. And we came up with a standard practice, a standard approach to the evaluation of these patients, and it includes an evaluation, a general screen of the immune system. Because depending on your findings, it may push you in different directions, both diagnostically as well as therapeutically. I'll let Dr. Olson add anything.
Sure, I think that was a perfect summary. I think I would only add to what was in the chat here, which is the first word that I think we both missed the first go round was hypophosphatasia. And autoimmune disorders. Hypophosphatasia in and of itself is a metabolic syndrome, and it can be caused by a number of different things. So the answer to whether or not it's linked to MDS probably is determined by the cause of it. There are a couple of syndromes in early childhood that you can see a combination of bone mineralization abnormalities, skin abnormalities, and a few other things that go along with it, something that's called dysautonomia, that can be associated with predisposition to developing MDS. There is a syndrome that was originally described in 2016 that goes by the acronym MIRAGE syndrome, which links a lot of those things together. I want to be clear, though, that the vast majority of childhood eczema cases are not linked to MDS. And the majority of bone mineralization problems with phosphate levels and calcium levels are also not clearly linked to MDS. But there are rare syndromes where there is a link there.
That's a good point. It's not the eczema per se that is linked to MDS, but sometimes eczema can present in the context of a condition that can predispose to MDS. That's a good point. We don't want everybody worrying about eczema.
Thank you. Are patients who have had their spleen removed predisposed to cancer?
So I may have to turn to Dr. Shimamura on this one. To my knowledge, I am not aware of that predisposition directly. There is a risk of thrombosis if you've had your spleen removed. But to my knowledge, there is not a direct link there. Although I might stand corrected if Dr. Shimamura knows otherwise.
No, I'm not aware of a connection there either. So basically the risks typically with splenectomy are infection, of course, and in some conditions, thrombosis, meaning blood clots. Not for everybody, but in a subset of patients. But it's something that we are keeping an eye on because we're interested in this interplay between the immune system and cancer, but we've not seen that kind of association with splenectomy.
Our next question. My child was recently diagnosed with pediatric PNH. Do either of you have any experience with pediatric patients using Ultomiris, which was recently approved for pediatrics? And what has been, I guess, the outcome for patients?
So maybe I'll start with that one. So we've certainly had experience treating PNH in children. It's rare, right? And there are a variety of different agents that one can use. And so I think it really depends on the situation. Let me just, because I tend not to use the trade name. So Ultomiris is, maybe Dr. Olson can help me out here. Is that the?
Ravulizumab.
Sorry, which one?
Ravulizumab.
Ravulizumab, got it.
Yep.
Thank you. So we actually do have a patient right now, a child who we're treating with ravulizumab, and it's been working as you might expect with eculizumab, but it's, of course, has many advantages. You don't have to give it as frequently, and it's easier to monitor, and but it's been quite successful. So, but experience in pediatrics is still limited, I would say. Dr. Olson, I don't know if you've treated a lot of patients with that.
I don't think any of us in pediatrics have treated a lot of PNH patients. And since Ultomiris is relatively new, I think if you added up all of us across the country, you might get the experience of a dozen or 2 dozen patients in the pediatric space. So it's we don't have a lot, but I have a little, and it seems to work quite well. The monitoring is a little bit different than with the conventional eculizumab monitoring. I think the labs that we usually check for to make sure that the complement blockade is sufficient are oftentimes a little bit more elevated with Ultomiris than with eculizumab, but it doesn't mean that it is not successfully preventing severe anemia or the risk of blood clots, which are a couple of the things that we worry about the most with PNH. I would just maybe go a little bit tangentially with this question and answer the unasked question, which is why is PNH so rare in kids? One of the reasons that it seems to be different in kids is oftentimes when we are dealing with PNH clones in kids, it's at a time where there is concurrent aplasia. And so you have a patient who has severely low blood counts at the same time that you detect a PNH clone. And in those patients in my center, if the PNH clone is fairly significant, but they're aplastic at the same time, we really strongly think about transplant in those patients, which can eradicate the PNH clone in addition to help the cure the aplastic anemia in and of itself. It seems to be more rare in kids that the clinical presentation is the full-blown PNH, and the aplastic anemia is not present with it. Full-blown PNH, where the bone marrow has fully recovered with cells that contain the mutation in the gene called PIGA, which leads to PNH, is more difficult to apply a transplant to. And so that tends to be more of the presentation that you see in adults who develop PNH, where you sort of miss the aplastic phase, or perhaps they never had an aplastic phase, but they have full-blown PNH. And so that happens more in adults, which is why I think most of the experience with using complement inhibition is in adults, but it does happen occasionally in pediatric patients too.
We'll just add an exciting update, which is, it's been difficult to convince pharmaceutical companies to include children in their trials. And NAPEC has recently been approached by a couple of pharmaceutical companies that are piloting new approaches to treat PNH. And so we hope that we'll have data on more of these agents available for you for children. So it's an exciting time, and I think that's been part of the strength of forming this consortia. It's been appealing to pharmaceutical companies if they think that they can enroll children quickly to test these agents to see if they're helpful for the children, because typically children have been sort of lagging way behind clinical trials for adults, and agents weren't available to them in a timely way. So I think it's an exciting time.
What is next generation sequencing?
I think you're up for this one, Tim.
I am up for this one, but this is a topic near and dear to Dr. Shimamura's research program, so I think I'm going to defer to you.
All right, thank you. So next generation sequencing, without getting into a lot of details, is a high throughput way to sequence the genes, and it also gives us a much more powerful way to analyze the genes than the standard approaches that have been used in the past. So it's basically a way to describe this modern approaches to sequencing lots of genes quickly in a way that allows us to do much more detailed analyses. And this is being applied now. You may have heard of whole exome sequencing, which is available clinically, where we sequence all the coding regions of the genome. So if you think about our genome, it's our DNA. There are regions of our DNA that actually code for proteins or products that make us who we are, right? It tells us how tall we're going to be, the color of our hair, and then in between the coding regions, which actually encode for something that gives us information, there's DNA in between that doesn't really seem to code for a product. That's called an intervening sequence. If you think about it, the way our genetic counselors describe it, let's say you're watching a TV show. And you're watching the show, that's your coding region. And then in between you have the commercials that have nothing to do with your show, but there they are in your, as you're watching TV, that's the intervening sequences, right? But we're finding that the intervening sequences actually do encode or regulate how information is accessible or provided. And it also helps us understand how the genes are arranged and can show us different types of ways that the genome can go awry that we can't pick up by whole exome sequencing. So there's even more cutting edge sort of technologies that are coming available now to get around some of the limitations that we have. So what I'm telling people in my clinic are, if we've looked, let's say you have monosomy 7 MDS and we can't find the typical reasons for that, we keep looking. So long after we do that initial deep dive, we'll keep looking year after year. And in some cases, we've been able to find answers, either because of advances in technology or because new information becomes available that now we can apply. So don't give up. You should keep looking, and also our understanding of how to analyze the genome has advanced. So I've had patients come to me from outside centers. They show me their genetic report, which at the time it was done several years ago at their local center, it couldn't be interpreted, but now with modern knowledge, I've been able to come up with a diagnosis. So I think that these are just things to be aware of. It's a rapidly moving field. And Dr. Olson is also pioneering some approaches to try to do some risk stratification for aplastic anemia. We're delighted to be working with him on that. So stay tuned. I think there's a lot more excitement to be coming.
Yeah, I'll just follow up on that and say what we're specifically using next generation sequencing to do in our research group is to look at patterns of how patients with aplastic anemia actually lose expression on their cell surface of the very HLA genes that we use to match donors and recipients during transplant. Those HLA genes are they encode the proteins that sort of license the T cells that drive the immune response in aplastic anemia. And we're learning a lot about risk factors for developing aplastic anemia, as well as whether these HLA genes might actually determine what the risk of a patient is for going on to develop MDS out of aplastic anemia, based on what their patterns of HLA are and how these HLA genes end up getting deleted in the bone marrow cells of these patients to try to avoid the bad immune response in aplastic anemia. So next generation sequencing is a critical tool, I think, that's going to allow the next generation of discoveries to try to come up with better treatment options and understand the process of why aplastic anemia develops.
Maybe I would just add to that the approach that we're taking, which is complementary to Dr. Olson's approach, and we're really excited about his project. Our group has been looking at the acquired mutations in bone marrow failure and trying to understand how the patterns of these acquired mutations that are looked at through next generation sequencing can inform risk of progression to complications such as MDS, for example. And on the research side, we're able to go much deeper than we can as a clinical test. And so I would encourage people to consider whether you want to partner with researchers to help accelerate this. We can't do it without your input. And we're so grateful to all of you who have participated in these studies. Thank you all so much.
Well, thank you so much, Dr. Olson and Dr. Shimamura, for spending your time and your expertise with us today and answering all of these wonderful questions that have been submitted by parents and family. So thank you so much. If you'd like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking on the replay button. Or you can also navigate the on-demand tab in the platform hub. If you have any additional questions, you're welcome to send them to us in 3 ways. You can send it to our help account, which is help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. This is the end of our conference. However, we'll have a few closing remarks. We hope that you'll join us at 4 o'clock. On behalf of the foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. On behalf of our medical advisory board and team, we are always here to support you and your family, as we've done for the past 37 years. This concludes our program.